In this virtual conference, we will be discussing issues specifically dealing with the geriatric population. Our topic for discussion is reducing and treating delirium in the hospital setting for elderly patients. As we dive further into this topic, we will help you guys identify the risk for hospital delirium, as well as ways to treat and reduce hospital delirium. With as many as 7 million Americans experiencing hospital-induced delirium each year, this is a big topic. Hospital-induced delirium can further cause health issues as well as prolonged hospital stays.
Of delirium in the elderly. 1/3 of the general medical patients 70 years or older will experience delirium. And half of these patients that experience delirium, they start their hospitalizations with it. The other half develop symptoms after hospitalizations have started. Delirium is the most common surgical side effect in older adults. There is 50% chance of developing this after high-risk surgeries such as hip fracture repair or cardiac surgeries. Delirium is present in 10 to 15% of older adults that are brought into the emergency department. When patients who are receiving palliative care and the end of life approaches, 85% of people will experience delirium. We often think of delirium as being agitated or hyperactive. This type of delirium represents only 25% of the cases. Other cases we may not recognize are categorized as hypoactive delirium or quiet delirium. Quiet delirium is associated with poorer prognosis because it is less frequently recognized. Features of delirium range from mild to extremely severe. With greater severity, the worse the outcomes. And causes and complications of delirium in the hospitalized elderly. Symptoms of delirium vary. Fluctuating levels of consciousness resulting in hypoactive delirium, which is a patient may appear sleepy or be withdrawn or depressed. Hyperactive delirium is when a patient will be agitated and restless and may sometimes exhibit combative behavior. They may have difficulty maintaining concentration, disorientation to person, place, time, or situation, difficulty retaining new information, visual hallucinations, difficulty maintaining a conversation, disorganized thought patterns. These are changes that occur in a short period of time over hours or days and typically worsen in the afternoon or evening, also known as sundown. Causes of delirium. Predisposing factors are older age, over the age of 65, dementia, functional disabilities, male sex, poor vision and or hearing, lab abnormalities, alcohol abuse. Precipitating factors, drugs, especially sedative, hypnotics, and anticholinergics. Surgery, anesthesia, high pain levels, infection, acute illness, acute exacerbation of chronic illness, and sleep deprivation. Complications of delirium. Increased length of hospital stay, increased healthcare cost, increased mortality both in the hospital and 6 months after post-discharge, acute cognitive decline, increased risk of injury, disability, loss of independence, and decreased quality of life, increased chance of discharge to a rehab or skilled nursing facility, and increased 30-day readmission rates. And references for this mini slide.
The prevention of delirium in our hospitalized older adults. About 10% of our adults over the age of 75 have already developed some form of delirium upon admission to the hospital, and then another 8% will develop delirium while they're hospitalized. Some of our patients that come in with delirium are patients with pre-existing dementia, those that are acutely ill are patients that come in with pneumonia or influenza, urinary tract infections, are patients with sensory impairments, or acute stroke patients, and then patients that have decreased mobility. For patients that develop delirium are at increased risk for falls, injuries, longer hospital stays, and those longer hospital stays can lead to the need for admission to skilled nursing facility after their acute hospital stay. Delirium is often under-recognized and underdiagnosed in the hospital setting, and prevention and management of delirium can improve health outcomes for our older adults. The Australian Commission on Safety and Quality in Healthcare Delirium Clinical Care Standard lists 7 focus areas for hospitals to prevent delirium. Those areas are early screening of delirium, early assessments, early interventions, early identification of the underlying cause of delirium, prevention of injuries associated with delirium, and decrease the need for antipsychotics in the treatment for delirium, and then a better transition to home. There was a clinical trial in Australia where they introduced an assistant workforce to the hospital setting, especially in the emergency department. So they introduced what they called older person technical assistants, or OPTAs, and they were used to help reduce the incidence of delirium in the hospitalized older adults. The OPTA is a trained healthcare assistant, and they specialize in older adult care. They work under the delegation and supervision of a registered nurse, and they provide supportive care and screening with the older adults. They support the nurse in delivering quality care in the 7 focus areas of the delirium clinical care standard that we talked about in the previous screen. And they're also there to provide one-on-one care for our patients that come in, maybe that 10% that comes in with delirium. Some of the roles and responsibilities of the OPTA: they are there to greet and orient the patient to the new setting, to the department, orient the patient to the rooms. They're there to assure safety, make sure the call bell's in reach, the bed is low and locked, make sure the patient has access to all their belongings, their glasses, hearing aids, whatever that may be. They are there to help get the patients changed into a hospital gown if that's appropriate for that setting, assist with toileting and ADLs as needed, and be there for therapeutic activities like reading the newspaper or book, playing puzzles, games, to help the patient. The OPTAs also, in this clinical trial, they were there to provide screening tools to guide patient care. So screening tools like the 6-item screener to identify cognitive impairment. It's used a lot in emergency departments. The confusion assessment method instruments for delirium, fall risk tools, pain scales, many nutritional assessments, things like that. In the conclusion of the study, they found that the OPTAs were able to reproduce the results of the screening tools that were previously administered by the nurses, which showed they were competent in the administration of the screening tools. So they came up with the same values as the nurses came up with those tools. They delivered quality supportive care to prevent delirium in the hospitalized older adults. The documented rate of screening for delirium and supportive care to the older adults improved with the OPTA involvement. And the OPTAs assisted in raising the awareness of the need for supportive care for our older patients for delirium prevention while they are hospitalized.
In the next slide, we will be talking about treating delirium. In the New England Journal of Medicine, Dr. Mark Antonio had a list of ways to treat hospital delirium. As always, we like to start with the least invasive or least involved and then advance to the more invasive or more involved treatment. The first way that he suggested treating delirium was to identify any underlying causes that could be contributing to the delirium. Always patients could have more than one thing wrong with them that brought them to the hospital, or things can always develop during their hospital stay. So assessing the patient for an underlying infection, dehydration, or ruling out the possibility of a stroke is a good way to make sure that you are realizing that it is in fact hospital delirium before moving forward with treatment. Another thing that he suggested was managing the agitation without pharmacological methods. This could be as easy as just optimizing your environment for your patient, keeping the lights on during the day, keeping it dark at night, encouraging the family to visit just to help keep the patient grounded. He also suggested that we avoid wrist restraints or physical restraints. This could increase the agitation for the patient. I know a lot of the times patients feel like they're in jail if we tie them to the bed, and we want to avoid that if at all possible. The other thing that we can do, and this is the last most involved method, is treat the patient with an antipsychotic. This basically sedates the patient. Even though the studies are not really sure why this works for the patients, the best that I could probably come up with is that sleep sometimes is the best medicine. Just resetting that clock, helping these patients rest, heal, and then wake them up and reorient them with their family's help is a good way to treat hospital delirium.
Summarizing the reduction of delirium in older hospitalized patients. So prevent inpatient admissions would be to minimize the need for inpatient care, perform exercises to help with balance and strength. Identifying those at risk are people over the age of 75 years old, individuals with dementia, history of alcohol abuse, recent anesthesia, infection, sleep deprivation, and we use the screening tools such as CAM, fall risk assessments, and pain assessments to identify those patients at risk for delirium. Treatment of delirium is to reverse possible causes, avoid agitating patients, and optimize sleep schedules.